I'm with Catepillar, and chances are if you've driven on a road, landed at an airport, used copper in any kind of household appliances or tubes or anything at all like that, we've been involved in your life in some way. So Catepillar is very heavily involved in earth moving equipment and mining and a whole raft of things. And just real quickly, we're 100 and so thousand employees across the globe. About half or so are in the U.S. and half are outside the U.S. I'm an internist. We have more of a medical model, I think, for our health promotion program, partly because of our demographics. We're an older male-dominated population, and we suffer with a lot of diabetes, heart disease, and cancer. And the other part of it is that I'm an internist, and so I tend to think of things more medically. So I want to just take a couple of seconds, and I'll be brief, but talk about some of the things that we've been doing around health promotion and well-being at Catepillar. For us, it really starts with data. And so we devised our own HRA a number of years ago, and really it's a dynamic product that allows us to dig into populations and dig second and third levels down. So if we're talking about smoking, we start talking about, are you ready to quit? And then we start talking about, what are your drivers? What are your pros and cons? So we can build that along the way. So that's been a very useful tool for us. HRAs are somewhat, I think, still of some value for behavioral change, but much more importantly, HRAs for us are important for data. And we really have to have data. I need data to know what programs I want to have for our employees. And so we put a huge incentive out there to get HRA completions. And so we have, for our spouses, retirees, and employees, so that's 100,000 people in our programs, we've got a 97% HRA completion rate year after year, and that's getting it twice a year. So we survey our population twice a year, and we get that data, so we want to see what's going on. That's really important for me and for our program. We have to have the information to know where to drive programs. So what we've done then is take that data, we merged it with demographics, with some biometrics, we're working on that, with claims data and pharmacy data, and all that resides in a big warehouse. And so we take that warehouse and we take all that information, and we've developed our own risk stratification with a big assist from John over there. John helped me with this a couple of years ago, but we've developed our own weighted scoring system to put people into buckets. So we've got everybody at Catepillar is either at the highest level of risk all the way down to the lowest level of risk. And then we can cut and paste that, not paste it, we can cut it wherever we want to make those cut points to say that we have, these are our healthy population. The group that's healthy at low risk, we really want to give them information to try to help them stay there. You've heard all this before. The group that is healthy but at moderate to high risk, we then target interventions for those folks. And so the higher your level of risk, now these aren't sick people, these are healthy people, but the higher your level of risk within that strata of being healthy, the higher the risk, the more we work with you. And that's where Healthways has been a great partner for us. We put on-site coaches at our facilities and we tie it to the HRA. So if you complete an HRA and you turn out that your health score is less than 80, you're going to get a call and then from a health coach, and then an attempt to try to invite you into a program around reducing, for us, what the main issues are is cancer and cardiovascular risk. So we've really focused on those issues. Now, for transparency, I got to say that you probably, I don't know if you're familiar, but Catepillar last year was a $51 billion company. This year, we're probably going to be more like $35 billion. So we're really seeing the effects of this recession. So some of the things that I'm talking about, we've had to suspend temporarily just because cash is king, and we're at the point now where we have to have cash on hand, and so we've had to cut some things back. This is really a once-in-a-lifetime recession event for those of us at Catepillar. But notwithstanding that, the philosophy is target the population, and then as you find those people at higher level of risk, offer more intense intervention. And then the other piece that we've done now is we've gone back to our artificial intelligence folks at Catepillar. We have a lot of researchers. I don't know what those guys do. They sit in dark rooms in front of computers all day long. But they've developed some really interesting artificial intelligence tools to predict engine failure. So I've been working with them over the last couple of years, and we've taken those tools, it's called Proceed, that software, it's really a predictive modeling software, and had the inputs, instead of being engine parts and engine clearances and dynamics, the inputs are health risks. And the inputs are things like age, smoking, diagnoses, drugs you're taking. And we had 103 variables then that we've sorted through those variables and come out with, on the other end, and we are now able to predict who's likely to develop diabetes or who's likely to develop heart disease. So that's a more robust way to target the right population. One of the things that we always worry about is that I want to target the people so that if you have no risk for heart disease, I don't really need to tell you about heart disease. But if you're at high risk for diabetes, I want to know that, and I want to be able to work on that with you, not with you, but with you. So we want low-risk people to be healthy. We want to more accurately find that high-risk group. Right now, it's that weighted risk score that we've got. We're working on validating the predictive modeling to really be able to more accurately do that. Our early studies show that about our high-risk group for heart disease, about 50% of those folks then went ahead and had a heart attack the next year. So we can find that high-risk group in a way, and so that allows us then to target our efforts really where they need to be. So it's a lot about getting the data, analyzing it, and try to target for the right kind of programs. Some other things along the way, we've been involved with tobacco cessation for a long time. We've got a 35% quit rate it's up to 6 years for people, because we measure it on a regular basis. So we know our participants and how well they've been able to do. One of the fun things we did a couple of years ago was that I took over food services. So food services at Catepillar now is a health promotion opportunity, and that's how we market it, and that's how we talk about it. So we have differential pricing. If you want a cheeseburger, it's $4.50, you can get it, but we'd rather have you have a grilled chicken sandwich with salt for $2. We mandated that all the vending machines have to have at least 25% low fat. They're on the right side. If you come to a Catepillar facility and look at a vending machine, on the right side is aggregated and marked. These are healthier products over here. If you want the Snickers bar, go ahead, but it's going to cost you $1. These are 70 cents. So we have differential pricing both in vending machines and at all of our dining centers. And we mandated that we do standard work. Everybody has to do that. The interesting thing with our vendor, they were really skittish about this. They weren't sure this was such a good idea, but we've now, in our vending machines, that 25% of healthy items is managing about 28 to 30% of sales. So it's staying ahead. And we've also put informatics into our cash register so we can, on the fly, see what's selling and what's not selling. And so when we introduced veggie burgers, for instance, we were selling at a lower price. We were selling $500 a month at our home office in Peoria. Once we dropped the price down and increased the hamburger price, that went to 2,500 sales per month, and we could just monitor that on a regular basis. So we've tried to do some fun things around food services. We're a conservative, stodgy company, and so fun is not really in our vocabulary, so that's kind of a challenge for us. But we're trying to do the best we can with it, and the food service has been kind of a fun opportunity. Other things, diabetes prevention, our health. If you have diabetes or we can identify that you're at risk for diabetes, we ask you to get into a special program that goes on for 3 to 4 years, and it's around preventing diabetes, which is the most important part. The second part is if you have diabetes, we measure you around 5 axes. We want your A1C under less than 7, LDL cholesterol less than 100, blood pressure controlled, on aspirin unless contraindicated, and not smoking. And that composite is what we measure. And so when we look for people that are candidates for our program, we go out in our database and find people that are not at the composite. If you're already at that composite, we love you and stay with it, and we'll check on you in 6 months. But if you're not at the composite, then we put you in the program. And so we have about our population that enters our diabetes program, there are about 2 or 3% of them are at goal for all 5 things, because we're not perfect in terms of getting people in the program. A year later, that 3% moves to 24%. So 24% of our diabetics are at composite goal for all 5 of those things. That's what prevents cardiovascular mortality. You know, I say all the time, diabetes is not a blood sugar problem. Diabetes is a vascular problem with a blood sugar hooked up to it. And so it's the vascular issues that cause the problem. So let's get at the problem. The core of the problem is all of these cardiovascular risk factors in a person with diabetes. So we set it up and say, this is what we're going to measure, and this is what we want you to try to get improved. So that's been a really good program for us, and we've been able to show that we can actually help people get to goal around diabetes. And then we've also used the diabetes prevention trial information to find that high-risk group that has insulin resistance and put them in a program around physical activity, exercise, weight maintenance, that sort of thing, to try to prevent the diabetes in the first place. So it's really about prevention. We're trying to move everything upstream as much as we can. I could go on for another hour, but I think we're about 10 minutes into a break. So I'm going to stop right there. I just want to give you a flavor for some of the things that we're doing. And it's for us, it's really around getting good data, using that data to have evidence-based programs in place, and then measuring what's happening, using that then to go on and make improvements. And that's really kind of the philosophy behind what we're doing as well. So with that, I'll stop, and if we have time for questions.